our session. Welcome to the Nourish webinar on the early results and themes of our food prescribing scan. I'm thrilled to be hosting this conversation, inviting Joshna Maharaj to share the exciting findings, strategic learnings, and strategic questions about food prescribing as we learn from the pilots across the country and what's happening on the ground, really in this transparent way of building food as medicine to build upstream health. So I'll just introduce myself. I'm the co-executive director of Nourish. Our mission is to advance food for health across the country through innovation, raising awareness, and facilitating action by the healthcare sector to address the pressures that our current food system and issues of sustainability and equity put on it. So those are issues like food insecurity, diet-related disease, the carbon footprint itself of healthcare's service delivery, and the colonization of indigenous food sovereignty. So today we're going to be hosting this conversation about a really exciting area of strategy to have systems change that really embeds food as medicine to really build health upstream and to help us create more resilient food systems to meet the moment of climate change and calls for equity. So I am really thrilled to have Joshna join. She'll share the findings of the scan for discussion. We really invite you to jump into the chat and pose your questions as we're going. And then we have Sarah Stern with the Maple Leaf Center for Food Security, who will be sharing her vision as it's evolving and learning a lot from the US basically explosion of investment in food as medicine. And then we'll open it up for a discussion about what's emerging and what we think is the potential for bringing this forward and getting greater investment and scaling out across the country. So welcome, Joshna. And
Thank
you
you
have some slides, I think, to share with us today.
I do. I do.
So
Hello, everybody. It's lovely to be here with you. I have been super excited about this project. Me and hospital food have a long relationship with each other, and food in healthcare and I have been at it for a while. And in fact, in 2011, when I was working in my first hospital project, I wanted to send recipes for soup up to the patients when we were making them. And just like on a bit of a lark, I formatted the recipe to look like a prescription. A little bit for a laugh, but also to send a message about what that soup could actually do. And so when this opportunity showed up, I was really, really excited to jump in and learn a bit more about what's happening. And I have exciting things to share. So let's get into it. Okay. Okay. All right, here we go.
you're a Renaissance woman, Joshna. There you go.
Thank you. So here's our team. I thought it important to just note, I was on the ground doing a bit of the legwork, but I had wonderful support from Jennifer and Shelby at Nourish to really put ideas together and really help this whole scan and the report take nice shape. So here's just a bit of a note on the methodology and how we pulled this all off. I did 1 hour interviews with 11 food prescribing programs in the country. I also had a chance to chat with 2 program funders, the Maple Leaf Center for Food Security, which is Sarah, who you'll speak to a little bit later on. And then I spoke with Catherine at CFCC, Canadian Community Food Centers Canada. And I had a wonderful chat with Sonia from the Canadian Institute for Social Prescribing. So it was, what I loved about this was that I got a chance to have a really holistic conversation around those sort of advocating around food prescribing, as well as those doing food prescribing. And these are the 4 questions that we went through. I really wanted to have questions that made enough space for folks to tell me about what they were doing. So what is your experience with food prescribing? In your opinion, what has worked well and what's less successful? What's required, in fact, for this to be a success and work? And then the $1 million question here is, how can this scale? How can we grow this ideally to a national level in a way that really does get plugged into our public healthcare system? So here's a little zoom in on the projects that I spoke to. They were all really diverse, and it was so interesting to see how in different regions of the country, ideas had to shift and change depending on the needs of the communities in those places. And that to me was super inspiring. We had a little concentration of folks in Southern Ontario, but the folks in Alberta and Saskatchewan are doing some fantastic things. About using both food packages and gift cards to really connect folks to good food. And what I thought was really great was that every project seemed to have a really interesting little bit of innovation, right? The fact that the folks at the Seed in Guelph had created a sliding scale market, both online and in person, to really help people maximize their access to things. The University of Calgary's randomized controlled trial introduced the idea of the use of a CSA as part of an employee benefits program, which I think is wonderfully fascinating. And then our friends at Food First in St. John's talked about the fact that for them, gift cards were important because for their strong Indigenous population, sometimes the gift card is required for the gas for a skidoo or some ammunition for a hunter so that they could get their hands on traditional country food for the community. Another thing that was interesting, Black Creek Community Health Center really spoke and focused on what they called a Black food prescription. And I liked the boldness of just narrowing in on a community that needed support and service this way, and to think about what the food stories are behind those cultural focuses. So for clarity, down at the bottom, the Community Food Centers Canada Market Greens program was across the country, which is why they're not specifically arrowed here on this map. But they really focused on, it was sort of a multi-layered piece with a focus on folks who are diabetic, or I think also pre-diabetic. They created subsidized markets to offer this kind of access to beautiful fresh produce for people. And one more thing that I loved so much, innovative use of a hospital cafeteria. Hospital cafeterias are so important place to me. And the wonderful team in Montreal has repurposed their hospital cafeteria and brought what sounds like a whole bunch of life and excitement to that place by their prescriptions are just access to meals in the cafeteria. And that's the fact that you have so many different pockets of people sitting down together enjoying meals felt very, very exciting. So here's a little bit more about what we found. There are a couple of food graphs here. On the left, we have the comparison of projects using coupons or gift cards versus those offering food packages. And as you can see, slightly more offering the coupon and gift card. And we will get into that understanding a bit more. On the right, you see a comparison of whether or not these prescriptions were offered in healthcare or non-healthcare spaces. And it feels encouraging to see that just a little more than half are being offered in healthcare spaces. Although, for sure, we love a community food center and we love a community access point. But when we think about prescribing, having an anchor in healthcare feels like an important piece. One of the most important nuggets, I think, of the data is the fact that 100% of the projects that we spoke to were focusing on food insecurity. And it's a really conspicuous piece. Right? Everybody is offering projects that focus on food insecurity. The trick is they're not actually operating in a long-term way to promote healthy diets. And that is not a criticism at all. It's just more mention of the fact that food security, or food insecurity as it would be, is like a hole in the bucket, right? That's constantly leaking. And until we address it to some degree, we're not going to be able to move further with our thinking about what food prescribing can do, right? Our friends at Proof have released data recently to let us all know, terrifyingly, that national food insecurity has reached 23%. And I can only imagine what this means for northern communities already. When we, down south, we're at 16, 17% national, northern numbers were 52. So I feel like there's definite cause for alarm about how quickly those numbers are rising. And another piece too that was in that report was the fact that there's a pretty solid line for those who perhaps were formerly moderately food insecure have now rolled into being extremely food insecure. So there's lots of reasons for us to pay attention to this. And it's an important piece in our conversation about the viability and function of food prescribing. So here is the thing. Predominantly, the food insecurity is an income issue. This is a bit of truth that we all know and we understand. But food prescribing is a health tool, and this is the way we're very intentionally pitching this. The problem is we cannot use health policy alone to address what is fundamentally an income issue. Plus, there's another piece that said even if we did sort out the food security piece and magically had a solution to address poverty, there would still be a need and space for food prescribing. Even communities of people who have access to money, who have adequate income, things like that, their need for this knowledge and this program access is still quite strong and reasonable. So when we think about what food prescriptions can do, I think that at their best, food prescriptions are about supporting people to grow their own knowledge, build their food skills, and then develop some new habits, all in the interest of boosting their health. Right? That is really the anchor piece here. And this is sort of how we've framed the conversation. Now, this leads us right into the therapeutic use of food, which is what is on the other side, sort of the issue around food insecurity, right? Once we sort that out, what opens up is the idea of the therapeutic use of food. And so this is where I think a little bit of distinction is important because if so much of what is already happening can be to address food security is considered food prescribing, what is distinct about prescriptions? Why prescriptions? Why should we, focus our direction there? And so many of the leads and the folks that we spoke to on the ground said that food prescriptions are relevant for folks who are not food insecure, right? Which is the same message, and that food prescriptions can enable us to improve health while reducing long-term burdens on our healthcare systems and reliance on medical intervention. So food prescriptions can last outside of the scope of addressing food insecurity. And that's, to be honest, one of the most promising pieces there because there's more universal applicability thinking about across the country. So I love this quote. This is from Dinah Johnson at the Rockefeller Center. Food is medicine programs ranging from medically tailored meals to produce prescription programs are widely recognized as powerful interventions, but currently only reach a fraction of those who could benefit. So the understanding of the potential is pretty wide. We even see this from our friends across the pond in the UK. The use of food as medicine this way is really important for whole communities, not simply a focus on those who are food insecure. The lovely folks at Tufts have really broken this down in a way that I find quite compelling, right? So what this is a pyramid. I like the idea of various kinds of nutritional counseling and education. I think one of the most compelling pieces is this line on the left that takes us from the bottom around just population level policy at prevention to actual treatment, which is the medically tailored meals right up at the top. There's so much possibility here. The hospital food worker inside of me is delighted to see this description and this breakdown because there's so much more that we could be doing and using those hospital trays to teach and to feed people. And to see this articulation is helpful because what this helps me do, and those of us who are sort of deep in it, is create a bit of a continuum, right? Everybody is in a bit of a different place, different resources, different priorities. But if we build a continuum that takes us through these stages, starting more generally perhaps at a policy level, and then moving through more focus on people to end up with the gorgeous notion of medically tailored meals. I feel like that's the way that we're going to actually make this movement happen and this quiet revolution. I'm the one always pushing for the or not so quiet revolution. Okay, so when we think about what food prescriptions look like right now, the current vibe on food prescriptions is between these two offerings, either grocery gift cards or coupons in some cases, or food packages themselves. So the virtue of gift cards is that they allow participants to make their own choice. They can choose sometimes where they shop, offering agency and maintaining folks' dignity. It's not to say that food packages don't maintain dignity, but it is, the choice is really taken away. And sometimes, you know what I mean? Once choice and agency are taken away, particularly for vulnerable communities, dignity can get a bit compromised. It offers flexibility with what needs to be purchased. And one really interesting piece is that it saves on infrastructure needed to keep food storage. Right now, we're seeing food banks have really transformed their offerings, and a lot of the time they're purchasing food. So for a few participants across the country that I heard from said that it was easier for them to not have to invest in the infrastructure of food bank spaces, refrigeration, storage, that kind of thing, and to just invest that in having gift cards available. Now, on the other side of things, the food packages were actually really useful for particular communities. Isolated folks, seniors, people like that. The food package at the door was a really important piece. And being able to see a friendly face once a week to do a little check-in or a connection just to make sure people are doing well was part of that delivery. We heard lovely story from the Apple a Day folks in Saskatchewan about how the kids know now that Thursdays is the day when the Apple lady visits, right? So they're sweetly waiting on the stoop outside, for the friendly face and the bag of food. The other really cool opportunity with food packages is that that's how we offer direct connection with local farms and markets. And that is an important piece. We have farmers markets involved in a few of the projects. And the other lovely piece is the surprise that can come with the food package. Although we understand that there potentially is some limitation, there is also a delightful surprise to figure out what to do with kohlrabi and other lovely things like that that show up as a surprise that maybe people have never tasted before. But one of the things I think is important to note is part of the reason why gift cards seem to be so useful is because they're the closest that we can get to actually just putting money in people's hands, right? Which is how we can turn a health plan, a health program into addressing an income issue. This is the sort of patchwork way that folks on the ground are making this work. And so it's an important piece that needs to be acknowledged. There's a reason why the gift cards seem to work so well, because it allows people to offset budgets, you know what I mean, and just really manage their money.
Joshna, I just want to jump
Yes,
in because there's a
please.
pretty timely question in the chat that was
Yes.
posed, and maybe you can speak a little bit about if this
Yes.
was raised in the interviews that you did. So the question is about um, deciding or in framing up those in power, I guess, designing the programs who are deciding what is considered in quotes healthy for participants.
Mm-hmm.
And the sort of second frame of the question is, even with a gift card or voucher, there are still parameters about what you can buy and not buy. And this question is being framed by somebody who's had a lived experience of an eating disorder, who
Mm-hmm.
just has this as a kind of core question about what
Yep.
you were hearing from the pilots and other programs that have.
Mm-hmm. It's a really important one. Thank you for that.
Yeah.
And so there's a few things to say there. One is, you're right, there are limitations both in the stores that you can use gift cards at, and in some cases, there's conversation about limited access to certain items, right? And that can be really challenging. One of the things I think a lot of folks talked about, and to be honest, a lot of them mentioned the need to have more opportunities to build food literacy and to put the education piece in, right? Because really, one of the questions I asked was, what is the language on the actual prescription or the piece of paper? And overwhelmingly, the language is quite generic, and it just says things like fresh food or healthy food. So yes, I think that is an unaddressed piece about how we define healthy, who has the power to make that definition, and to what degree are people included in making their own decisions about what is good for them. Right? This is a hurdle I think that we're going to have to deal with as we build this program more formally, because this is absolutely not going to work if it becomes a really hilarious, to use the word prescriptive, but if it becomes a really sort of paternalistic top-down dictation about what is considered healthy. We have some problems, right? And it's not going to work. People, I think, need to be more engaged in making those choices themselves.
And I think too, I mean, a lot of these are constraints that, some of these early pilots or next steps are, a lot of this
Mhm.
is, it's not sufficiently funded for the full vision that
That's right.
probably everyone who's tried to do these programs has had in mind. So there are these kind of stepwise changes that I think we'll need to also envision. But
Yep.
I
Thank
think
you
you're
for
going to
that,
speak a
friend.
little bit more to some of that nuance. So yeah,
Yes.
thanks for answering that.
So once we the gift cards and the food packages is the current state. But once the wheels start turning here, there's so many beautiful options for how this could work. The meal kits is one that gets me super excited. The idea of medically tailored meal kits I think the revolution is right there. I laughed a lot about the fact when I went hunting for a graphic for a meal kit, the only option was for it to be a burger. Which speaks to who we are and how we're eating and where our desires and our tastes are. Because also a burger is an incredibly simple thing to make. Anyhow, the idea of cooking classes happening. My dream is that newly diagnosed diabetics or folks who, after a heart attack or something, before they are discharged from the hospital, they have a chance to go and have a little cooking class on site somewhere, right? That can help them build the skills to cook themselves the food that their body now needs. A boost in home cooking is something that we'd love to see. I've got so much experience in successful virtual cooking where everybody gets a package of food and then we join together on a Zoom call. And what I love about this is that it positions the hospital as a food hub, right? I've always dreamed that the gift shop in a hospital could transform into this wonderful food space with kitchen tools and recipe books and aprons and, all kinds of wonderful things to really support people on their way home from the hospital. Again, we have the mention of CSAs, community supported agriculture. The use of a CSA as an employee health benefit to me, this feels mega groundbreaking. Really, really exciting, both in the opportunity to support agriculture as well as to really understand the therapeutic use of food. Then we have tailored food prescriptions, the idea that we can drill down a bit and go beyond the idea of fresh food or healthy food to say if you've just gone through chemotherapy treatment, whole leafy greens, dark greens is the thing that you need. Or again, if you are a diabetic, let's get you connected to more whole grains. And then finally, the sweet notion that we could also do medically tailored meals that are delivered via Meals on Wheels, like we have to support our seniors. It's wonderful to get seniors any food because many of them struggle to put meals together. But if those meals could be a bit therapeutic and to support whatever's going on with their bodies, I feel like we're really going to be winning that. And the fact that there are this many possibilities and that really there are other possibilities that are not even here is really what has me so juiced up about this. I really think that there's a positive and possible future for a more health-based application in our relationships with food. Now, I'm going to shift thinking a little bit to think about the role of agriculture here. This is a tricky one, and I remember this so much from my hospital work, because I wanted, scratch made, culturally appropriate, locally sourced, sustainably made, like boom, boom, boom. And I had to realize that while those were all very worthwhile goals, we are not going to be able to make that whole move in one step. Right, I still had to get the institution used to the idea of scratch cooking on site of any ingredients at all. The notion of them having to be locally sourced or sustainably grown was just more than we could handle right now. And so the thing is, though, I believe that what we're trying to do here is build a continuum with multiple points of entry, as I mentioned before, but we have to build this imagining that at some point, once we're ready and the capacity is there, that agriculture we would have meaningful collaboration with agriculture and with farmers, right? Farmers have got to be farmers and our producers. There's cheesemakers, bread makers, all these other lovely folks as part of this story. They've got to be necessary partners. I'm thinking so much of Maurice Gervais, who is a berry farmer in Simcoe County here in Ontario. I called him because his strawberries were the first thing that I put on new patient menus, and I wanted him to sort of share the delight of that. And he said, fantastic. So you mean we're actually going to start using Ontario money to buy Ontario food to feed Ontario patients? Amazing. And yes, the answer very much is yes. And I told him I was going to steal that to put on a t-shirt. This notion of incorporating agriculture is not new. It is very much happening in other parts of the world. Our friends in Scandinavia are making mega moves to really build public policy that is anchored in sustainable food and agriculture. And so they've got this thing called the New Nordic Food Manifesto. You can look exactly that phrase up to get more details about what they're doing. But what they've done is sort of in an effort to try and preserve Scandinavian food ways and food traditions, they've really paired that with the idea that sustainably produced food ingredients are a necessary element to actually making that all work. Similarly, Dr. Stephen Chen, who is a really radical sort of revolutionary dude in California, he has a fantastic project and connection that really drills down and includes agriculture in his notion of what food prescribing or therapeutic use of food is. And I really appreciate this wisdom about the fact that both food and health industries pay no attention to land and soil. And in this current climate, both the changing one and the sort of socioeconomic one, more connections with agriculture to me and thankfully to my friends at Nourish feel like things that are vitally important. So this is our big major bid for the fact that agriculture has a really important role to play. In fact, I just heard lovely news about friends at the new farm in Creemore who are regenerative or growing, boosting their regenerative organic growing for their gorgeous salad greens. And they have had better success than they imagined. They found a way to grow regenerative greens more efficiently, and that has them instantly pulling the cost down at market to make it more available and accessible. And to me, that just lets us know that we, like planetary health, human health, all of it has to be built in together. And we have this wonderful network of humans working together to try and pull this off. This is from Stephen Chen. I think it's a really important note about why prioritizing equitably sourced regenerative and organic food for food as medicine matters. Right? I like this idea of a multiplier for benefits to human, economic, climate health, as well as the idea about health and racial equity, or a capitalist economic race to the bottom, right? Which is where industrial food keeps us pretty locked in there. And if we think about building programs to last and for the future, it makes perfect sense to me that we have to even just build with the idea of health and equity much more front of mind. Okay, so while we have the idea that food insecurity is fundamentally an income issue, the thing is that it is having significant impact on people's health. And that's why we are so steeped in this version of this conversation. And we want to talk through a little bit more about what that looks like, right? The pressures on healthcare and sort of remembering the piece that at any level, sort of provincial or federal, the healthcare budget is the biggest chunk. It's the biggest spend, right? And so the pressures on those healthcare budgets from diet are huge. These are some of the most commonly treated illnesses, and all of them have diet-related causes or exacerbation, right? And that's a really important thing for us to consider. Diabetes here is completely the low-hanging fruit, right? It is one condition that is so deeply connected to the management of a diet and the consumption of healthy food. And what I think is interesting on this next slide here is failing to meet Canada's healthy eating recommendations has an economic burden of disease costs. So it's both the underconsumption of healthy foods and the overconsumption of unhealthy food. So there's two angles here. It's like, what is the impact of folks eating a lot of food that's perhaps not great for the body, but also the cost of the missed opportunity of using food to support various diseases. And the idea that better nutrition could save the economy $100 to $200 billion a year is a really important place to land. And look, I am the kind of person who people constantly are asking me to make the business case for better hospital food or better school food, and I flatly refuse, because that thinking and those ideas are not appropriate as far as I see it. But the current state of our economy, of our healthcare system right now, is pushing this thinking. And there's some real truth here about the numbers and what disease, particularly disease caused or exacerbated by poor diet, is actually costing and is actually happening. So the numbers are compelling. And so even this girl who doesn't like to point to the numbers has to agree to point to the numbers, because it's all making so much more sense. Okay, so now I'm going to invite Sarah Stern to join us. Welcome. Sarah's from the Maple Leaf Center for Food Security, and she is one of the folks who I interviewed. And through the course of the interview, this awesome quote emerged as Sarah's ideal scenario or vision for how food prescribing could be, the viability. So here is her dream. Family healthcare practice does some food security screening, that offers patients an option that is right for them for food access. For lonely folks, it's vouchers for a community market. For a single mom with 2 jobs, it's a loaded gift card so she can go and buy what she needs. And for seniors, it's online shopping that is delivered to them. So welcome, Sarah. Lovely to have you. Thank you for taking the time to join us. And thank you for sharing all those bits in our interview. So we're here now. We've got some new data. There's existing data. This scan offered us some more data about the use of food prescribing, the real focus around supporting food insecurity at the moment. And then a few thoughts about what could happen later on and where this could grow. So I'd love it if you would share a little bit with us about your ideas, what's behind this fashioning of a dream you have, and some perhaps 1 or 2 important lessons that you've learned in your own investigation of this.
Thanks, Joshna. So exciting to hear some of the results of the scan that you've done and what's happening across the country. I know that we try to kind of stay on top of it and see what's happening, but it's hard to know because there is so much excitement and so much energy around the idea of food as medicine and those combinations. I think for the center, our focus is on seeing food insecurity in Canada reduced. And we really came across this idea of food prescribing and food as medicine through work that we've done with Nourish, with Community Food Centers Canada, and a lot of watching what's been going on south at the border. We got really curious about this because we know that most people who are food insecure, they're not going to a food charity, right? Only about 1/4 of people are entering the doors of a food charity. So we've thought, how do you reach people who are experiencing food insecurity? And we know, because of the consequences of diet-related issues that often are associated with people who are food insecure, they end up in healthcare. So it was, how do you leverage the scale that already exists to reach people, and what can you then do for them? Mm-hmm. Over the past, I think, 3 years now, about $8 billion has been invested in the US or committed in the US in the food as medicine movement. Wow. And a lot of that links to the medically tailored meals and this idea of produce prescriptions. So specifically, I saw there was a question that had come up around restrictions. A lot of the work that we've seen is specifically restricting gift cards or restricting delivery to fresh produce. It's often the thing that people can't afford, and it's the thing that may have the most impact on someone's health. Right. So we've been really interested in this. We've worked with CFCC, we've worked with other organizations funding some work in this space and trying to continue to develop a robust kind of level of data and information on this and seeing where it can take off. You shared all kinds of ideas on how this can work, and I think all of them can work. And to me, that ideal situation is it does have to be patient-centered, and it should, at least at the beginning, link to healthcare, right? If we're looking at prescribing food, it's not saying we don't still need to advocate for income solutions. We're looking at this as a health solution. Health budgets are so much bigger than social budgets or social support budgets. So if we can say this is a health intervention, this will likely reduce healthcare costs or decrease the number of emergency room visits by vulnerable people.
Mhm.
And because we're helping them live a healthier life, then you center the patient in it. They go in, they speak to their healthcare professional, and they get the prescription that's right for them. So the same way you might get a prescription for an antibiotic, they're going to look at what works for you. What is the right
Mhm.
thing? This would be the same. So I think in some cases it could be a card, some sort of reloadable restricted gift card.
Right.
And I do put that restriction because if we are saying this is a health prescription,
Mhm.
you could restrict it, whether it's just whole produce, whether it includes frozen produce, all
Mm.
of those things can be sorted potentially through technology.
Right.
That might work for somebody else who is socially isolated and vulnerable, and that networking becomes so important. Going to the community market that's only open 2 hours a week,
Mhm.
that's their time to not only get their fresh produce, but also engage with others.
That's right.
Versus someone who has a mobility issue. Let's
Mhm.
get the food right to their door. I think the opportunities are endless, but the goal would be let's improve health by addressing diet-related issues, by providing good quality, healthy food for individuals. And at the same time, that may reduce food insecurity.
Right. Right. I like that. I like that. The notion that with a health focus, the reduction of food insecurity is considered, but it kind of bumps down a bit from the top priority.
Yeah.
Right. And yeah.
I think in Canada, when you look at it, you'd likely include it as part of a screener, right?
Right.
So if you were a healthcare professional and you were screening for pre-diabetes, when I've spoken to community health centers, they would say pretty much everyone would be eligible. Everyone's good.
Right. Right.
Different social determinants of health. No one can afford good food. But you might do some screening. Because essentially, if we're treating this as medicine, it should be for anyone who needs it.
Right.
But if you can afford your food, you should be going out and purchasing it, right? So
That's right.
it's the balance. Our healthcare system should be paying for this. And so we need to develop the case of evidence that shows them that, yes, this is something that makes sense for us to invest in. Luckily, there is a lot of evidence already south of the border. There's evidence in the UK, evidence in Australia that is showing by making investments in healthy food, and it is largely fresh produce,
Mm-hmm.
you are having healthier patients. It's decreasing the burden on the healthcare system, and it is a good, worthy investment.
Yep. It's thank you for this. One of the things that really speaks loudly from what you're suggesting here is the idea that there is a community network. Right? We understand, just like our healthcare, one solution is not going to work for everybody in this country for a variety of reasons. And that, to me, it feels really compelling, because one of the things we heard from a few folks, particularly in the community health space, was that part of the reason why food prescribing hasn't been able to take off is that they don't really have the program to send people to, right? They don't have this community network of places outside of the context of sort of food banks, dining programs, things like that, to be able to offer to people as legitimate supports, the same way, at least best case scenario, that a more community health focused program does.
Yeah.
So building up those resources in their diversity, wherever we sort of decide to start, feels like a really important way to think about how we build this so that it's got strong legs and can actually last, run, and obviously be effective for people.
Yeah. And I do think in some ways it's being able to leverage infrastructure that we already have in Canada.
Right.
And obviously that level of infrastructure varies depending where you are, but being able to use that. And that
Right.
means in some cases it can be farmers markets and CSA boxes. And in other cases, it's walking into the mainstream, walking into any retail environment you want and having a card that can be used.
That's it.
Yeah.
Right.
You're in
That's an
Kensington one day
important
and
piece.
trying to do that. If you want to go into a grocery store, you can do that.
Yep. It's really good. And that really is also one of the ways that we ensure both effective support for folks and some sense of choice and agency and maintenance of dignity in all of that, right? Because, as I think that you mentioned earlier, the idea is that the person, the client, the patient is at the center of all of this decision making.
Yep. That would be the hope.
That's
How we get there,
right.
we're all
It's
working
true.
there.
Well, I do think that is a burning question. If you think of so many pressures on our healthcare system and how do we find these win-wins, I think getting to scale and the investment needed to see these returns and building health, it really is in front of us of how to build momentum and to build on that. I'm glad you brought in that, Sarah, that building on the evidence that already exists seems like a huge opportunity in front of us to not reinvent the wheel, the R&D, rob and duplicate, that we really just want to try to move as quickly as we can, obviously respecting and designing these programs to meet the needs of specific populations and places. But I think we have a pretty good case to bring to the sector for further.
Yeah, and I'd like to think it should be easier in Canada. In the US, when you're negotiating with payers, you're negotiating with Medicare and Medicaid, which are the government programs,
Right.
plus private insurers. And a lot of private insurers are now running these programs.
Mm-hmm.
In Canada, we have, I'm gonna have bad brain today, but I would say 12 or 13 payers.
Yeah.
Right? The provinces and
Yeah.
territories are the payers. Right. So you just need to have those negotiations and have them agree to it, which is not as simple as I'd like it to be.
No, but I like the notion that it could be.
Yeah.
Right. And that one of the virtues or advantages of public healthcare is that levers can be pulled this way. Right. And that we can do things that can be sort of extrapolated and shared across the country this way. Thank you for that, Sarah. I really, really appreciate that perspective and the support of these ideas. Okay, friends, we are now going to turn over to you. We would love to hear from you. We'd love to generate a bit of conversation. Sarah, if you wish, you're super welcome to have your own private time, put your camera off if you're into it, do your thing. Thank you so much for that. But we've got some questions to suggest a discussion here. We're very open to answers to these questions or any questions that you've got. Pop it in the chat and we will pay attention to that and do our best to answer them. What
And
opportunities?
Sarah,
You got
you're
anything,
also
Jen?
invited to stay in this conversation if you want.
Oh, good. Yes.
We'd love
Oh,
to
good.
have
We
your
have that capacity.
perspective.
Wonderful.
Yeah,
Great.
it's okay. But I know you have I'd have another meeting to jump onto. But
Yes.
yeah, I think it would be great because you've really been in touch with a lot of what's emerging in the US, particularly, which again, as you shared, it's a different context, but the core, that transparency, I think that's offered by that insurer player is much more clear. It's more transparent. And I think it is an opportunity to bring that into the Canadian context conversation. Yeah. We did have a question from the chat, Joshna. Would that be a good place to start? So
please.
Julia's question, in the US, the momentum, and that's why I wanted to bring you back into actually, Sarah.
She knew. Okay.
In the US, the momentum, her question is, in the US, the momentum around food as medicine has now started to recognize the importance of food skills interventions alongside the food provision. And newer frameworks are showing teaching kitchen interventions and culinary medicine as key components. So I think that's the infrastructure piece you sort of dreamed about there, Joshna. Totally. And maybe the culinary medicine piece is actually on the healthcare professional capacity development, and seeing food as medicine literally being a bigger part of training and healthcare understanding of how health is promoted and sustained. So I guess
I
I'm
also
just curious.
think, though, I think that there was something else I'd like to augment that idea with, is the idea that we bring the notion of culinary medicine to chefs and to the way we raise our chefs and have more chefs with this knowledge. Because I think having more chefs on the ground to be able to support these programs, what we do as cooks is make things work with very crazy circumstances, right? And limited resources. And so to be able to bring chefs into this and to also do some teaching to them about the impact that food has and thinking through restaurant food. Like, when have we ever stopped to think about whether restaurant food is actually good for your bodies? Right? And can take care of you. And maybe as cooks, we need to think through a little bit more about what we're feeding people, right? And because really we can be, right, in some cases, mega dispensers of so much refined food product that is not really doing anything good to anybody's body, right? And it's an important decision to make. And I think that there should be space for a chef, for a young or aspiring chef, to chase that track and that path around health and food if they so choose, which then opens us up to the idea of having more formalized notion of chefs in places like hospital, school, and prison kitchens.
Yeah. And I love that idea of activating this leadership across food and health
Right.
around food for health, because I do think there's just that it's such a personal issue, usually food, how you feel it connects you to your family, to your
That's right.
community, to the land, to what you know about it, maybe to your culture. If you've moved to Canada from another place, it's just, it's so core. So I think there's a huge opportunity to find a well of hope, I think, in it as well,
Yep.
and personal connection. Because I think in trying to change these big systems, that's something, again and again, that emerges from our work with our communities of practice, that connecting into people's values is a really powerful way to help everybody do the hard work of making these systems
That's right.
adapt and change to the evolving needs.
That's right.
I
I'm
think,
curious, Sarah, do you have a spin on the kind of food skill development, or what you've heard about from your conversations or immersion into some of the US models, what you
yeah,
see being successful there?
I think that the idea of knowledge and nutrition comes up a lot. And
Mm.
it's not that people don't know, but sometimes you don't know everything, right? So how you build those things together. And I'd share two examples. I had the opportunity to be, you shared the Tufts pyramid earlier, and I had the opportunity to go to their Food as Medicine conference this year.
Nice.
And the keynote speaker on the first day was the CEO of JP Morgan, which is Manulife in the US. And he said, we're interested in this because we're life insurers. No one
Mm.
is going to benefit more from people living longer. No one's going to make more money from people living longer outside of like life insurance, right? You keep alive, you make more money.
There's a serious bit of truth there. Sure.
Yeah. So different
That's
people
getting
have different
dark.
motivations. But so what they're doing is they do food prescribing, but they've also got an app, and they're doing all kinds of behavior change and knowledge sharing through that app as well. It would
Right.
improve healthier living. So if you're getting a food prescription, you're also going to get nudges and thoughts about healthy menus, healthy cooking, and demonstrations. So I think that was kind of one example from a private sector, really cynical reason to be involved,
Mm-hmm.
maybe practical, depending on how you look at it, but
That's it.
they're betting big on this.
Right.
I also heard someone from YouTube speak. And you might
Okay.
think, what does YouTube have to do with food as medicine?
Mm.
They are doing after school cooking classes and after school food knowledge classes for kids.
Oh, I
So when you
love
think
it.
about how to drive change, like we think about the recycling movement, right? It's
Yeah.
things we may have learned in school, your kids learned in school, or your parents, depending on how old you are, we all learned about this and took it home.
Yep.
So the
Yep.
same goes if you think about school, you think in Canada now, the power of a school food program, what we can teach kids in school that they're going to take home. In the US, from a food as medicine perspective, it is happening online and on YouTube, and they're working with popular kids chefs and popular programs
Oh,
and
good.
broadcasting that out. So it's a way that knowledge is getting embedded across everything.
It's amazing. And I feel like this resonance of just thinking of life shifting, or everybody's experience of where healthy food can be available, where you can engage with it, and
Mhm.
where we eat, work, play. I mean, it's just an amazing, really achievable, I think. And there's so much exciting work happening that reinforces, I think, healthcare's investment in this, that,
Right.
yeah.
Amazing.
Two more questions that have
Yeah.
been in the chat. One is, Joshna, you get a big thumbs up for your amazing, contagious enthusiasm for this. So just a
Thank
little
you.
bask
I'm
in the
so
glory
glad.
of that. And the question is, what has been the biggest surprise for you from doing the scan and delving into this big topic?
That's a great question. Thank you for that and for those sweet props. One of the biggest surprises for me is how much we don't like how on board people are with the idea of food as medicine. Right? My first hospital food project was in 2011, and I feel like I did a lot of teaching while delivering a project, right? And sort of explaining why these connections needed to be made, particularly thinking about the food we are feeding to hospital patients. But it is so lovely and so delightful to see that wisdom is now, we're at the 2.0 on this. We're standing firm on the idea that food is an essential component to building and nurturing health. And now it's like, okay, how do we actually pull this off? Right? And to see what that opened us up to, right? Getting that as a baseline bit of knowledge has now opened us up to so much creativity and innovation. And that to me is really, really important. The other thing that I think it's not necessarily that it was a surprise, but to see the evidence in front of me of the deep interconnection of communities and food, right? The fact that, the wonderful wisdom about gas for the skidoos, right, in Newfoundland, to actually, figuring out ways to engage markets, to pack up bags that get delivered to isolated folks in apartment buildings in deep urban centers, right, is just it's more evidence of the fact that our food, it's right there in front of us, right? I mean, listen, there are times where I'm just like, for God's sake, what's it going to take? Why is this so hard? Right? Why is this such a hard challenge when it's such a fundamental thing? But it is so encouraging to see the momentum that is growing. And that's something that I have been really happy that I had the chance to do this work. It's been like a nice sort of next stage in my relationship with people and their relationship with food, let's say.
Yeah, amazing. That's great. There's another question that I think though that kind of goes back to, or as you mentioned, like how are we going to get there? I think
Right.
there was a question about in the scan what emerged as themes. I mean, you weren't able to talk to everybody who is doing produce prescription. There are the two well-known ones in Nova Scotia and BC that have a
Right.
farmers market focus, and you had focused on ones trying to snowball where there was an element of prescription. Can you speak a little bit more about what that element of prescribing was, who was doing it, what the maybe barriers and opportunities are there in envisioning a kind of at scale food prescribing, what you learned from the scan?
Yes. And so the idea of prescribing, it was a lot of community healthcare at the community healthcare level, right? And to be honest, what was fascinating was that there was a real clear notion that it was any health practitioner. It wasn't necessarily something specifically in the seat of physicians, right? There were OTs and BTs who were talking through the need for food prescribing as well, which is important because even just thinking through the role of physicians here, I had a chance to talk to a couple of doctors, and in all of my work, I have felt that there's like a doctor-shaped space, right, that hasn't been filled yet, and that's something that was a bit conspicuous to me. And when we pulled the thread on that to figure out what's behind it, largely it is because the idea of the therapeutic use of food or the role of nutrition is not something that we raise our doctors with, right? It's not part of the education model that they receive. It's really sometimes just a few hours of conversation that medical students get about all of this. So there is, as a result, until we see more connections in the education and raising of doctors to bring some of these ideas in, we open them out to all healthcare practitioners to be able to be the ones to offer these prescriptions. Now, in a more community anchored space, I think that because food insecurity is the sort of monster that it is right now, a lot of things were being called prescriptions, and it's just I think there's a kind of newness to that idea that perks people's eyes up, and it makes it a bit perhaps more interesting, as opposed to sometimes the difficulty that can emerge with food banks and food bank hampers and packages and that sort of thing. And so that is, to me, it was really interesting. I wanted more juiciness in the topic about what the language was on the prescriptions, right? I wanted there to be more, but invariably, right? It was a relatively generic mood, sometimes healthy food, sometimes fresh food. And that it's where we are and it's where we're starting, but I would like to see that grow. And I'd like to see that develop. And that's both about wisdom, knowledge, and the resources to offer a program on the side of the practitioner or the prescriber, and then the capacity to actually use that prescription on behalf of the client or the patient.
Josh,
Sarah,
my
I'm
sense,
sure you've got some things to add there.
I would say my sense in Canada, and I'm not sure if this is what you heard as well, is that I would say we've got a whole stream of food security initiatives where people are given vouchers or cards or boxes, not because of a health related issue, but because of an income related issue.
That's right.
And we've got a lot of those. BC Farmers Market Coupon, Nova Scotia, like those are them. Carrefour Solidaire has an amazing program, the Carte Proximité or the Tomat, right? those are all like that. The program in Newfoundland that I think came up in your scan that we're funding, it goes through family resource centers.
That's right.
It's more, you're coming here, you're low income, we are going to provide you this benefit, versus a more tailored health program where you have to go through some sort of health professional to get the prescription. And so I kind of, when I try to talk about it, I say we've got the food security projects and then the health related food prescription programs.
Right.
And those are starting to emerge more and more, but they're still pretty nascent here.
That's a great distinction. Thank you, Sarah.
And there's a lot of, again, some of these questions that we're not, what are we going to need in terms of the data or the systems to support this to work well for the system and for patients and their families or communities. I think there is a lot in this next phase. If we look at getting investment, it's looking at how does the electronic medical record capture this data? What's the right kind of screening tool, and how are we going to kind of capture some of that, the learning about the experience of it, but also how it does impact and generate insight into how people are using the system and how that system better designing itself over time to meet need. Because I think this is, as we look at, there's a lot of complexity in supporting populations to be healthy. Of course, that's so clear. But I think
you've reminded me.
Programs,
you've reminded me,
that through will be important.
Jennifer, that the overarching spirit and the thing that I heard most frequently from the program leads who I spoke to was that we all just need to lift the priority of food, right? We need to rethink and reconnect. Food needs to become more important to us than it is, right? Because that part of the reason why we're in this mess is because of the systemic deprioritization of food, both accessing it, preparing it, cooking it, having time to eat it, right? I just spoke to a bunch of wonderful university students about who are trying to rebuild their campus food systems. And one of their main complaints was less about the food on the plates and more about no time and space to sit down and eat on campus. Which is an important piece. Not enough benches or tables, or a crammed schedule that has them, no time to sit because they have to move between campuses or classrooms, right? And so they have to have food that's portable that they can literally shove in their mouths on a bus or something like that. So the role that food plays in nurturing a life and keeping people and communities healthy is too low. Right? We need to care more about our food, about how it's grown, about how we're eating it, about who does and does not have access to it, right? Particularly when we're at a point where almost a quarter of our population is food insecure. The fallout of that is so dangerous. And so again, this is the same thing. This is the same stuff that I've been peddling for a long time, but we just have to care more. We have to invest more and care more about our food and our relationship with it.
We have only a few minutes left. There's a few questions coming in. One was kind of bringing in a disability justice lens into this. So I'll just use a longer framing of that. But I think you just sort of spoke eloquently to that the importance of thinking of specific populations and the design of these in service of, having people at the table in the design to make sure that the needs are being surfaced, and as we are developing the program and getting the investment, that we can be addressing them. I don't know if you have anything you want to add, but I also know we have 2 minutes left.
Yes.
so Joshna, Sarah, I don't know if you want to kind of wrap that one up. I think there's another question too, just about physicians not being trained or not being as aware in the field as other healthcare professionals might be, like dietitians, and there's a lot of specialties in food that are all part of our big healthcare system. So maybe you want to have the final word. I think
there's a wonderful opportunity here for our dietitian friends, right? I've had many conversations trying to mostly, to be honest, build bridges between chefs and dietitians. We are famously sort of separated populations, let's say. And I think that if we look at the scan of the practitioners we have, our nutritionists and our dietitians have the biggest reservoir of wisdom and knowledge. So let's use that. Let's build on that and engage them in a way until we perhaps get everybody else sort of on the same page. I see so much promise in what nutritionists and dietitians can offer in supporting both the creation and then facilitation of these programs.
I would just say, I think related to both, it goes back to it's got to be patient and user centered. So
Right.
they have to
Yes.
have, when you look at someone with a disability, you have to be able to offer them the program that is going to work best for them, which means we need a whole menu of programs to offer people. And I think for physicians, I think dietitians, as you said, nutritionists play a huge role. There's also a lot of continuing education. I know from the US, I think they have 4 hours of nutrition education through medical school, but as they're doing updates and certifications, there are now entire like webinars, courses
Oh, lovely.
specifically
Okay.
for doctors connected to food as medicine.
Amazing. Well, thank you so much, everyone. Joshna, Sarah, maybe we'll just wrap with a kind of recap of what's next for the field
Yes,
scan.
yes, yes. I
Joshna, I'll give that
realized
to you.
we are here. We were supposed to ask you all this. We got a little caught up in our conversation. I'm sorry.
All good.
But the report, the major report, I spoke to this. In addition to this web session, part of what we're working on is an actual tangible final report with more details about results from the scan, possibilities, and what we're working on. So we're working on some of the design and final editing on the piece. I am very, very excited about it. And so we're hoping to have it ready to share with all of you further on in the middle of July. So look out for it. We will be loud with our broadcast once it's ready. So that is coming soon. Thanks so much.
Thank you again. Thank you, Joshna, Sarah. This has been really exciting. Hopefully, I know some exciting conversations have been happening, and another note in that. And I think we've got just an amazing potential for food as medicine in front of us in Canada. So
amazing.
excited.
Thank you, Nourish, for opening up this conversation. I'm so delighted to have been able to jump back into this with you. And again, Sarah, thank you for both leadership and some big ideas. We're really appreciative of what you and then by proxy, what Maple Leaf can offer here for this to support these ideas in growing. All right. And thanks to all of you for joining us. Having this excitement is a really wonderful thing.
Thanks, everyone.
Have a great